So, good afternoon. My name is Moran. I'm a second-year resident at Sheba Medical Center, and I have another case scenario for you. So, we have another clinical case, and the story is as following. This is a 34-year-old male with no significant medical history. He arrived at the ER following head trauma. On physical examination, he has a Glasgow Coma Scale of 15 out of 15, with no motor or neurological deficits. But because he still complained of headaches, he underwent a CT scan. And in the CT scan, we see this bony lesion. We can see an expansile bony lesion. We can see a thickened inner and outer plate. We can see the cortex is thickened yet intact. And within the lesion, where the corticomedullary differentiation is expected, we can see ground glass opacities. We can see that there is no soft tissue reaction. We can see that there is no effect on the adjacent brain tissue. And we can see that there is no aggressive periosteal reaction. So, what would be the diagnosis? Is it Paget disease, fibrous dysplasia, eosinophilic granuloma, or giant cell tumor? Okay, so the correct answer is fibrous dysplasia, and we will talk about this entity for a bit. So this is a non-neoplastic tumor-like process. It is a localized defect in osteoblastic differentiation and maturation, which causes replacement of normal bone with large fibrous stroma and islands of immature woven bone. It usually affects young adults, and 75% of patients would be under the age of 30, with a peak incidence between the ages 3 and 15 years of age. We differentiate between two forms of fibrous dysplasia. One is a true craniofacial form, which is a monoaesthetic disease. It would affect only the skull, only the craniofacial bones. It could be a single lesion or multiple lesion, but only in the craniofacial area. And we have a polyostotic disease, which can affect the craniofacial area and any other bone in the body. We will talk about polyostotic fibrous dysplasia some more later. Regarding the craniofacial bones, the anterior bones are frequently more involved. We're talking about sphenoid, frontal, maxillary, ethmoid bones being more affected than occipital and temporal bones. And now, if we're talking about polyostotic fibrous dysplasia, then where is the most common place we can find them? Isn't in the tibia, in the pelvis, in the femur, or in skull and facial bones? What do you think? Okay, so I think you were correct, and this is the femur. In polyostotic fibrous dysplasia, the femur would be involved in over 90% of the cases. The tibia is in second place. It would be involved in 80% of the cases. Pelvis would be involved in around 75%, and the skull and facial bones would be affected only in 50% of the cases. We can also see polyostotic fibrous dysplasia as a main feature in two genetic syndromes. The more common one is the McKean-Albright syndrome. Besides polyostotic fibrous dysplasia, it contains precocious puberty, some other endocrinopathy, either hyperthyroidism, Cushing, acromegaly, or vitamin D resistance, and decapheal leaf spots. Another more rare genetic syndrome would be a Maas-Brout syndrome. It consists also of polyostotic fibrous dysplasia and multiple intramuscular myxomas, typically in large muscle groups. So, what about differential diagnosis? We can see here 4 cases of expansile bone lesions, only one of which would be fibrous dysplasia. We can see in the lower right corner, this is fibrous dysplasia. Above it, it's intraosseous meningioma. On the left upper corner, we can see cemento-ossifying fibroma. And in the left lower corner, this is Paget disease. So the actual list of differential diagnoses is quite long. This is just few of the differential diagnoses. And sometimes it could be really hard to differentiate between these entities. Paget disease would usually involve the clavarial vault and would less involve the anterior bones of the face, which, as we said, fibrous dysplasia like to involve. Cemento-ossifying fibroma could be quite similar, and the only differentiation would be in the pathology slides. In cemento-ossifying fibroma, we see a rimming of osteoblasts, which doesn't exist in fibrous dysplasia. And of course, we have to remember the sclerotic mats. It could be from prostate cancer, breast cancer, transitional cell carcinoma, lymphoma, etc. Sclerotic mass usually would be less expansile to the bone, and usually the age demographics would be a bit different than fibrous dysplasia. So, what is the next step with our patient? Do we just leave him alone? Do we refer him to a neurosurgeon prior to a surgery to remove this lesion? Do we send him to further investigation like magnetic resonance imaging? Or can we localize, can we treat the lesion locally with radiotherapy? What do you think? Exactly, so whoever said that was right, do not touch. Usually fibrous dysplasia patient experience no symptoms. It is an incidental finding in imaging, and the right method to go is to do not touch these lesions. When do we do something? When patients experiencing symptoms. And then we can consider sending them to further imaging studies or refer them to a neurosurgeon prior to a surgery. And what kind of symptoms am I talking about? Well, usually they would be due to cosmetic or mass effect. We can talk about cranial asymmetry, facial deformity, nasal stuffiness, proptosis, or visual impairment or unilateral blindness. In these cases, the course of treatment would be surgery to remove the lesion. Radiotherapy was actually used couples of years ago, but today is contraindicated since it was found out that radiotherapy causes malignant transformation of fibrous dysplasia. Regarding the surgery, there is a controversy regarding the best approach, whether early or late approach, minimal or radical resection. And we have to remember that sometimes these lesions could be quite large, so complete excision could be quite challenging, and also reconstruction could be quite challenging. So as for our patient, he came back on the following month, and he complained of persistent headache. He complained of hearing disturbances, of visual disturbances of his right eye. And so because he was such a young patient, we know he has fibrous dysplasia, but we have to rule out any other entities. He was referred to an MRI scan. So here we can see a T2 weighted image. It is without contrast media administration. And we can see the expansile bone lesion. We can see the intact yet thickened cortex. And we can see within the lesion, in the intraosseous part, a cystic-like component with high signal on T2. And they're correlating with the ground glass opacities we've seen in the CT scan. In the diffusion weighted image, we see a slightly enlarged of the signal. This would be to your left. But on the ADC mapping, we see that there is no true restriction. And after gadolinium administration, we can see that the intraosseous part of the lesion is heterogeneously enhanced. And this is the T1 images on the sagittal plane. To the left is prior to IV contrast media administration. And on the right, we can see the heterogeneous enhancement we talked about earlier. So this patient underwent surgery. I'm going to show you his pathology slides. And what do we see? We see in the slides, we see islands of trabecular bone surrounded by fibrous tissue, basically. We see no rimming of osteoblasts. And so we can see the small islands of woven, immature trabecular bone surrounded with fibrous tissue. And in a larger view, we can see that the trabecular bone are irregularly shaped. They have this curvilinear arrangement, which kind of reminds us of Chinese letters. And this is the classical histopathology appearance of fibrous dysplasia, Chinese letters. And this will be the last slide, so thank you very much for listening.